Good afternoon, Cassidy. Can you hear me okay?
Hi, you sound great. It's good to see you. Thank you.
Yeah, thank you. Thanks for being here. Okay, it's 1 o'clock. I'll call to order the Green Mountain Care Board's hearing of August 30th. Today we have a brief agenda. We have a staff presentation by Director Lindberg and Staff Attorney McCracken relating to the deliberative process we'll be using for the hospital budgets this year. And we'll have an overview of some standard conditions. And so with that, I'll turn it directly over to Director Lindberg and Mr. McCracken.
The slides coming through for folks?
Yes.
Okay, thank you all. For the record, I'm Sarah Lindberg, the Director of Health Systems Finance for the Green Mountain Care Board, and I'm joined today by Russ McCracken, our stellar staff attorney. The overview of what we hope to accomplish today is just review the deliberative process for the fiscal year 2024 hospital budgets, review standard order conditions for those budgets, review the public comment that we've received to date, and start to do some deliberations for the hospitals that were able to submit budgets under the benchmark for Gifford Medical Center and Rutland Regional Medical Center. So each year, the Green Mountain Care Board establishes budgets for the 14 community hospitals. In that review, the board considers many factors, including labor expenses, utilization, pharmaceutical expenses, cost inflation, commercial price changes, financial indicators, known pricing changes for Medicare, Medicaid, uncompensated care, and other factors, as well as testimony from hospitals and comments from members of the public. The guidance also outlines that the GMCB will execute its statutory duties consistent with its purpose to promote the general good of Vermont as set forth in 18 VSA 9372, to review and establish hospital budgets consistent with the principles for healthcare reform as required by statute, and we shall review and establish budgets in adherence to the requirements of 18 VSA 9456. So sorry to read a slide to you, but all important detail there. As I'm very well aware, all these decisions must be made by September 15th, with the written orders being issued to the hospitals by October 1st. If folks are interested in more detail about that process, we do have some more information on our website that people can check out. We're in the process of enhancing this process. That's a lot of processes. But as we look to improve and further adapt this process, we want to look to expand it in future years to include things like quality, more measures of productivity, getting some solid indicators for patient access, incorporating equity, consumer affordability, and considering the possibility of per capita budgeting. This is a step toward that end. So this is not the end all be all, and probably will be a work in progress for the next year. However, the main enhancements that have come to pass this year are using publicly available data sources to understand how Vermont's expense growth compares with peers nationally and regionally. The fiscal year 24 guidance inherited a benchmark that was established in the fiscal year 23 guidance. That guidance used a 2-year growth rate that was designed to be responsive to the desire of hospitals to look at budgeting over several years, and also to account for some of the historic inflationary pressures and workforce challenges that cropped up in the wake of the global pandemic presented by COVID-19. That growth benchmark was 8.6% in net patient revenue and fixed prospective payment, which I often will refer to as NPR, of 8.6% from fiscal year 22 actuals to fiscal year 24 budgets. That number comes from the goals established in Vermont's all-payer model, which is tied to the growth in the gross state product. When that model was negotiated, depending on whether you looked back 5 or 10 years, the range of the growth was between 3.5 and 4.3%. So the idea there being that hospital growth should be in line with the rest of the economy. We know that it has not been standard economic conditions over the past few years, but that was the litmus test that the state has dedicated itself through payment reform activities. So the way we'll approach this deliberative process is to start with a very simple but difficult question. Is that NPR at or below benchmark? Difficult in that it was an extremely ambitious target, which I think was acknowledged throughout this process. So for those hospitals, what we want to see is if the assumptions used were reasonable, and if so, we would recommend that those are approved as submitted. If any of those don't seem reasonable or are not supported by the submission, then we would recommend considering modification. However, for those hospitals that exceed the benchmark, so their NPR growth was in excess of that 8.6% from fiscal year 22 actuals to fiscal year 24 budgets, we want to see how each expense factor identified in the guidance compares with the reference ranges. And if it's in line with that, that gives us more confidence in the number that was used to establish that budget. And if not, that's when we might consider modification. So we used new data sources, as I mentioned earlier, that were identified in the guidance that was established this year, back in March of 2023. And what we have for labor expense growth was a median of 5.2% with a range of 0.8 to 9.7%. That comes from the Economic Cost Index. Utilization is based on historical trends in Vermont and has a median of a decline of negative 0.4% and a range of minus 5.5% to 4.2%. Pharmaceutical expense growth is one that I think folks are grappling with across the spectrum in our delivery system. And as you can see there, the median growth is 12% here, according to the national data, with a range of 2.3 to 21.6%. So no doubt that that is a cost pressure facing a lot of hospitals, and not just in Vermont, but across the nation. Cost inflation more broadly is at 5.8%, again, nationally, over time, with a range of 1.1 to 10.5%. So see that over time that we can have a lot of variability in these estimates, but at least we can know what it's looked like over time. For commercial price changes, we will look at comparisons with inflationary measures and the relative prices of hospitals. The financial indicators will vary by that indicator. So those are things like operating margins and days cash on hand. Known pricing changes for Medicare and Medicaid. We want to know that those were factored into the budgets and that there was diligence done to make sure that they were accounted for. And similarly for uncompensated care, we're most acutely aware of the market disruption caused by the end of the federal public health emergency, which has led to Medicaid redeterminations starting back up after a few years off. So we expect to see some market shifts, and we want to know that hospitals thought about that and did some homework about how to account for that in their budgets. And there's always a catch-all category. So for some hospitals, there might be some individual factors or circumstances that we want to consider in the deliberative process. And now I'll turn it over to Russ.
Great, thank you, Sarah. I'm going to walk through some proposed, what we're calling standard budget conditions. Before I do that, I'll explain that these would be effectively a default set of conditions that the board would include with each budget approval or modification. But it's and our discussion today is not specific to any hospital, and these conditions are not specific to any hospital. So as the board goes through each hospital, through the deliberations process, and approves or modifies a budget, the board can attach these default conditions, or if appropriate for a particular hospital situation, can modify these conditions or add to them as needed. So that's why we're referring to them here as the standard budget conditions. So I'll walk through. Most will look familiar from prior years. We've made some drafting changes, and I'll highlight that. The first is simply approval of the NPR growth rate as a percentage over the FY22 actual NPR to be consistent with the guidance. And so the board will approve a total NPR of not more than a certain amount for FY24 for the hospital. The next condition is an approval of the overall commercial rate increase as a percentage over the current level for the hospital, so over its FY23 levels. We've made some additional clarifications here to make explicit what I think has always been the board's intention with this condition, with this approval. So the first one is to say that the commercial rate increase overall will be capped at a certain percentage, and that cap applies equally to each different payer. So if it were, say, a 5% increase, the board intended that 5% increase to apply overall and for each commercial contract. Part C is a continuation of making more explicit what has been the board's intent in this commercial rate cap. And it's to say that the commercial rate cap really is a cap. It's a maximum. It's subject to negotiation between the hospital and its commercial insurers. It's not a rate approved by the GMCB that constitutes some kind of amount that's set or guaranteed by the board in the hospital's negotiation with insurers. It's really intended as a cap subject to negotiation between the parties. So I'm going to move into the next couple of conditions, which I kind of group all together. We can stay on the slide for a minute, Sarah, which I grouped together as, no, sorry, go back one slide. As reporting conditions for the hospitals. So D, which is new from prior years, says that the hospital's expected commercial NPR, which we can estimate based on the budget as approved by the board, is a certain amount. And the condition is requiring the hospital to report its actual expected commercial NPR by February 15th and explain what accounts for any variations between what we've estimated based on the budget submission and what is actual. There are a couple of reasons there might be variations in this. There could be a change in payer mix. There could be some other factors. So we're asking the hospitals to report back and explain that difference. Sarah, is there anything else you wanted to add on this particular condition?
I would say that this is a step as we try to continue to move towards measuring what we want to measure and measuring it in such a way that we can check our work and make sure that things are sugaring out the way we intended.
Thanks. The next condition, oh, sorry, one more on the prior slide before I go. This is a change from prior years. We would be requiring hospitals to report actual year-to-date performance only kind of once between budget cycles on April 30th for the period from October 1 to March 31. Previously, we had reporting done quarterly, which we then modified to kind of twice during the budget cycle. So with this, we would have this one interim report on April 30th. We would receive projections for FY24 when hospitals submit their FY25 budgets in July of next year. And then obviously we'd still collect year-end actuals for FY24 in early 2025. All right, next slide, Sarah. Here we have some broad, here we have, I think, what are familiar conditions around reporting. The hospital will have to submit its FY23 actuals, on or before January 31, 2024. Hospital has to file its FY23 audited financials the earlier of 15 days after the hospital receives its audited financial statements, or January 31. The hospital, to the extent determined by the board chair that would be helpful, the hospital will participate in phone calls, check-ins about the hospital's operating performance. The hospital should advise the board of any material changes to its FY24 budget or expenses. Should include assumptions used in determining the budget, so changes in their reimbursements, additions or reductions in programs or services, and any other event that could materially change the NPR that the board approves for FY24. Next slide, Sarah. Again, a continuation of conditions or a condition that looks familiar from prior years. The hospital shall participate in the board's strategic sustainability planning process pursuant to Act 167. The hospital shall timely file all forms and information required for the practice acquisitions or transfers as determined by board staff. There's a board policy on reporting provider acquisitions or transfers, so this is a condition that relates back to that. Hospital shall file all requested data or other information in a timely manner. And then I have some boilerplate things here. After notice and an opportunity to be heard, the board can amend the provisions consistent with its authority in statute and rule. All materials can be provided electronically, and findings and orders in these orders do not bind the board's future decision making. So I believe on the next slide, I did offer some motion language around approving these budgets, approving these conditions. I know from some individual discussions with board members, there may be, we may not be in a position to do that today. So I would open it up for discussion, and we can always approve. The board can always take up approval of these conditions at the meeting next week. And then I think I turn it.
Yeah,
Sarah, do I turn it back to you, or do I turn it to board discussion?
Yeah, why don't we turn to the board discussion before we move on, if that suits the board?
I think that makes sense. Let's hear any thoughts or suggestions board members had on the standard conditions that were presented.
I'm happy to hop in here. I like the standard conditions. I like the amendments to them. So thank you, Russ and team. I wanted to throw in another one for possible consideration by the board, and it relates to wait times monitoring. Again, this year, most but not all hospitals actually complied with our guidance to submit both referral lag and visit lag on their practices and top radiology procedures. So I think in order to ensure compliance next year, I would like to add a standard condition or a requirement that hospitals incorporate a system to be able to track and monitor both referral lag and visit lag so that we have 100% compliance by next year.
One quick question, Member Holmes. That sounds like a good suggestion to me, given the access and delay problems we hear about. Would we need to be more prescriptive to ensure that everyone has a uniform measure for measuring these?
I think the guidance that we put together last March is pretty clear on what's expected, but we might be able to revisit what that language said and make sure that that's standard and apples to apples across different, hospitals, and everybody understands what is being measured. But I thought we did a pretty good job of making clear what we needed. I think there were some hospitals, it sounded like from some of our budget hearings, that just didn't have the systems in place to be able to record that. So I think by giving this much lead time, the hope is that they can put the systems in place to be able to monitor and track it. But I'm happy to hear about ways to standardize it better, and if the staff or others have ideas, that'd be great. I just think it's really, as you said, it's really important we, are monitoring wait times. We have serious access issues across the state, and if we're not measuring referral lag and visit lag, we don't know where the problems are.
Okay, thank you.
Any other board response? We certainly will do some homework on that and can circle back with some suggested language, but didn't know if there's anything else we should consider as we do that. All right, sounds like we've got a takeaway. Any other discussion on this? Okay, so it sounds like we're not ready for a vote today, but we will take that up at the next meeting and move along. So shifting gears to review the public comment. The comments were more robust, I'd say, this year than in previous years, from my understanding. So we had a total, I think now actually recently, of 151 comments. Of those, the vast majority were related to a situation of how reimbursement for staff at a certain health network should be meted out. And then we also look at, we got the second most common set of comments was related to exercising the GMCB's full authority to limit increases. We had a few comments that a specific health network shouldn't have any limitations on the revenue that they seek. And finally, just a single comment that we should approve the GMCB should approve budgets that support each hospital's need. I do want to highlight that we did get a very substantive comment letter from the healthcare advocate that included analysis of the UVM Health Network's audited financials, and they also offered their recommendations about what action they would recommend on the budgets for the hospitals for the board to review. So again, uncommon to get this many comments, but that is how it worked out this year. So I think this might be a good opportunity to see if there's any other public comment before we really dig into the hospital specific deliberation process.
Good afternoon, Mr. Chair. Mike Fisher here.
Mike, how are you? Please go ahead.
Thank you. I wanted to just say a few words as you enter into this next stage, not about any specific hospital, but about the process. As you know, as it was just stated, we provided a written comment, and we of course stand by that comment, and there's no need to repeat anything here. But we did want to offer that if you have any questions or clarifications about the details we provided in that comment, we are happy to engage and work to get you the best answers we can. I just want to recognize it's not easy to be the regulator in the situation in front of you. Yet, regulator you are. You have this very challenging task of finding the best path between the expressions of financial need from the hospitals and the comments from the likes of the HCA and others about the consequences of a healthcare spending that's growing faster than real wage growth on Vermonters. We appreciate the clear evidence-driven process that was rolled out this year. It was a significant improvement from past years. We also want to recognize that there are a handful of hospitals that did hard work and effectively reduced their budgets without cutting medical without cutting services. We think the hard work of evaluating the budgets of those hospitals who significantly exceeded the guidance, in evaluating those hospitals who significantly exceeded the guidance, it's important and respectful to remember those hospitals who lived within or close to within the guidance. A few years ago, we challenged ourselves at the HCA to always bring up health equity in every proceeding, to ask the question, what's the health equity angle? I want to recognize that we didn't do that in this year's hospital budget hearings, and tell you a little bit why. We reached out to sort of in follow-up to last year's hospital budget process, where we raised a number of questions about clinical race equity questions. I think the example of which was spirometry, the race adjustment for spirometry that is common. In follow-up to that, we did have a meeting with the Hospital Association's CMO Council, and started the work of trying to raise issues of race equity, clinical equity questions there, to attempt to have a system-wide approach to those questions. I think this is good. I don't think it's great. It doesn't. It's good that we have a forum and a process to go forward to raise those questions, but it's not systemic enough, in my opinion, to really bring experts to the table to ask those questions and to understand where we're doing well and where we're failing in different hospitals. We've been raising the question, the relationship between bad debt and free care for a lot of years before you. And I want to express a little frustration. After all these years, I still don't have confidence that hospitals are reporting to you the value of those items, free care and bad debt, in a consistent and reasonable way. This makes it hard for me to push hospitals to do a better job of engaging with patients who are having troubles paying their bills, and make sure they're evaluated for eligibility for free care. We heard from a number of hospitals this year who say that people just won't respond. No one ever said this was easy. Yet some hospitals appear to do a better job of engaging their patients about their financial assistance policies than others. Many of you know I'm a social worker by training. In the best of the human service model, when we fail, we don't say there's something wrong with the client. We ask, what's wrong with our approach? We know I believe there are ways to effectively engage patients and to make sure that they know about the financial assistance that's available to them, and look forward to a day when we can hold hospitals, when we can measure hospitals' efforts on this level. Again, thank you in advance for your work. We're hopeful and know that you will find a way to keep the affordability of Vermonters in mind as you make the tough decisions in front of you. Thank you, Mr. Chair.
Thank you very much, Mr. Fisher. Any other public comment?
Chair Foster, this is Tom Walsh. I wanted to ask the healthcare advocate if he has a preferred methodology for measuring the bad debt to free care ratio. And if so, if he could share that with us. How would you prefer it be calculated? Is there a gold standard, or what are the strengths and weaknesses of your approach? I'd like to learn more about that.
Member Walsh, I'd be happy to engage here or happy to engage later about how to do that.
Okay. I think written would be helpful for us. We can consider incorporating that into our guidance.
Yep. Yes, thank you.
Kelly Lang, you have your hand raised?
Thank you, Chair Foster. The comment is in regards to this special conditions proposed, and we just wanted to highlight and make note that the rates that are put in our budget are the commercial rates that are necessary and budgeted models on all payers providing that rate. So it is not seen as a maximum or variable between payers. If we could provide services at a lower commercial rate, that's how they would be provided to address the access that Professor Holmes noted and the quality. In regards to that, when you have the payer regulatory procedure in the payer orders, it's not where and how payers negotiate contracts. So this is a different standard. And we're trying to all address quality and access here on both sides. And we'd like to make that comment for the record.
Great, thank you. And I believe, Ms. Lang, just for the record, you work at UVM Health Network, is that right?
That is correct.
Great. Okay, thank you. The next hand, if folks are from entities that are regulated, it would be good to identify that just for the record. The next hand is Mark Stanislaus.
Hi, Chair Foster. Yeah, this is Mark Stanislaus from the University of Vermont Health Network, and I think this is more of a question on item D. I don't know if you can go to that one, Sarah. And Kelly might also have some comment on this too. Just to clarify what you're looking for. If it's from a dollar perspective, those rates go into effect on January. Many of those claims aren't even adjudicated for the first month by the 15th. So, we would have every intention to try to comply with this as much as possible. But, we just don't have the data to certify from a dollar perspective, from an actual GL perspective, Sarah, to, I think, answer this. I think we could be in a perspective to share the percentage that, where we landed potentially, but I just wanted to point that out. I don't know if item D is possible to do that by that date and, with any assurance that the number is correct, because those new rates go into place in January. I mean, our books aren't even closed for January until the end of February. And many times, depending on the timing of the negotiation, the fee schedule might not even be updated until February 1st versus January 1st. So I just wanted to point that out to you as it relates to item D for consideration. Thank you for this opportunity to share that.
Thank you. Director Lindberg, has condition D been included in prior year's budgets? Or is this
a new one? Yep. Yep. So we can certainly take that back and workshop it a bit to make sure it's it's something that can be responded to.
Any other public comment? Okay. Seeing none, Director Lindberg, if you want to keep on moving, that's fine with me.
Wonderful. So we will commence the deliberative process, starting with Gifford Medical Center, to review the request that Gifford made. The 2-year growth rate requested would result in a 7.7% 7.2% overall growth in net patient revenue and fixed prospective payments from the fiscal year 22 actuals to the fiscal year 24 submission. A note that this number includes an adjustment related to a provider transfer. There were some practices or components of the Gifford Health system that made more sense to transfer to the hospital versus the FQHC, under which owns the hospital. So that just explains the delta between the NPR that we will ultimately approve and the growth rate that we're approving. So we want to be complicit, we want to make sure that we're measuring growth in NPR appropriately and fairly. And as far as the charge increases that Gifford is expecting to use to get there, there was a 3.5% charge approved in fiscal year 22, a 3.65% rate, a charge increase approved in fiscal year 23, which when you look at the submission for fiscal year 24 is another 3.6%. So taking the 2 years, fiscal year 22 to the budget as submitted, we get to 7.25. Those are among some of the lowest rates that we see in this time period. So definitely demonstrating a low reliance on a rate increase. To be clear, a charge increase would affect all payers evenly and is not specific to commercial. So if we apply our decision tree, NPR is below the benchmark. So we next ask if the assumptions used to get there are reasonable. And when we look through the budget submission, we see that for labor expense, Gifford's been very active in that space. They recently implemented a wage analysis and they continue to review and adjust compensation based on market conditions. And they also, in the relatively recent past, have implemented a position control mechanism so that they can optimize the appropriate staffing levels. They're clear that their objectives are to pay a fair rate in order to retain and attract providers to the area. As far as utilization goes, they were above the historical benchmark there, and their higher than typical increase was related to the 2 provider transfers that we just mentioned. So they're adding OBGYN and neurology services. And they also had recently added a podiatrist, and they have a cardiologist who's ramping up. So there was certainly justification from prior assumptions from these areas that justified that utilization rate that was above typical for them. The cost inflation information they used, they provided plenty of detail. It aggregated out at 5% for pharmaceutical expenses, which was derived from information from their group purchasing organization. Their data was a little noisy in that they had some very high cost pharmaceuticals in 22 that for a patient that they are no longer caring for. So it looks a little funky in their financials. But as far as the pure cost inflation, that is within the benchmark. For non-pharmaceutical cost inflation, that was budgeted from a range between 1.5 and 4%, all within the benchmark. And again, based on information from their, that should read from their group purchasing organization. The requested rate increase for fiscal year 23 to 24 is the second lowest among all the submissions this year. They also demonstrated a CMI adjusted average cost per discharge below the median of their peer group in fiscal year 22, and their cost and cost coverage were among the lowest of Vermont critical access hospitals. This is driven in part to the fact that they have been unable to implement charge increases for the past couple of years as they've looked to restructure their charge master and implement their new electronic medical record system. So even if you net in those retrospective rate increases that they hope to realize, the rate growth is still within benchmark of what we would expect during this time period. For financial indicators, so when you think about Gifford, it's really important to remember that they look a lot different on what we call the consolidated basis than at the hospital level. So we see that Gifford Healthcare as an entity is struggling. They acknowledge that in their narrative. They talk about the measures that they're doing to try to improve their margin. But even if you just look at the hospital, most of the financial results are below median for indicators, but for the days cash on hand and debt to capitalization ratio. So, not seeing any drastic growth in margin or too much too fast when we talk about financial recovery from their submission. Gifford accounted for all known pricing changes in the submitted fiscal year 24 budget. So as a critical access hospital, most of their reimbursement from Medicare is going to be based on cost reports and is going to be based on the services that they did in fact provide. And finally, the assumptions that they use for the unwinding and Medicaid redeterminations was based on prevailing trends, and they, in their hearing, talked about how they approached that exercise. So according to the way the staff here see it, all those assumptions seemed reasonable, and we would suggest that this budget would be approved as submitted. So that is potential motion language for you to consider in the deliberation today.
Thank you. I'll open up to any board member questions or comments.
I had a question related to the charge increase. It looks like what you're suggesting is that in the order we basically stick with the increase for 23 to 24, and that the order is silent on, whatever happens on those prior increases. Is that right?
That's correct. Our thinking there, and Russ can help keep me honest, is that these orders have been framed such that they're increases above previously approved rates. And given that these were due to some operational challenges in the past few years, it did not give staff pause.
Okay. I just wanted to make sure I understood how that worked together with that. Thank you.
Yeah, and I would just say that I appreciated that they were so forthright and highlighting that they wouldn't have had to do that, frankly. So I thought that was that I appreciated that as a regulator.
Agreed. So I'm comfortable with the staff recommendation for this hospital without any changes, and I'm happy to make a motion if people are ready for that, but also happy to wait until there's more discussion.
I'm also okay with approving this as submitted and per the staff's recommendation here. A little concerned about the prior increases, just the precedent of potentially they didn't do that here, of banking them and then using them in the future as a different circumstance. But you can see if that were to happen in a different type of context, it could be a lot of money added to commercial unexpectedly pretty quickly, and that would be suboptimal. But I don't have a problem with this request, and I think this should be approved. Any other board member questions or comments? Member Lunge, you want to make the motion?
Sorry. I'm talking on mute. I would move to approve Gifford Medical Center's budget as submitted with a 7.2% increase from fiscal year 22 actuals to fiscal year 24 budgeted net patient revenue and fixed prospective payment, a 3.6% charge increase from fiscal year 23 to fiscal year 24 and subject to the standard budget conditions. With the caveat that those standard budget conditions have not yet been approved. So our future standard budget conditions.
Second that.
I'll second the motion. I'll give Dave the second. All those in favor, please say aye.
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 Mr. McCracken,
I'm sorry to interrupt. I wanted to see if you wanted to open up to any public comment before we did a vote, and then also just Sarah said this at the outset, but the 7.2% increase is giving adjustment effect to the provider transfers, and that'll be clear as it's written up. I just wanted to make sure I noted that here.
sorry, can you say it again? My computer froze up, so I went off video for a second because I couldn't hear it. Could you say it again?
Sure. No, I had the first was I wanted to see if the board would like to open this up to any public comment before voting. And then the second point was just to note again what Sarah said at the beginning, that the 7.2% increase is giving an adjustment for the provider transfers, as it's sort of noted on the prior slide, and that would be clear in the budget order. I just wanted to make sure it was clear for the motion as well.
Okay.
If it would be
I think
better, we can withdraw it and redo it if that would be better, Russ, because we used to have a separate vote on provider transfers in the past.
I think that was my mistake in not making a note here in the suggested motion language. But if you're
So
inclined
why
to,
don't we, I think it's okay if it's in the budget order and we all have that understanding. I think
Yeah.
I made a mistake in not calling for public comment before the vote, and I apologize for that. So why don't I take public comment? We have the motion, we have the second, and then we'll vote. So if anyone has public comment on the motion, please raise your hand. Okay. Seeing none, all those in favor of approving the motion, say aye.
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 Aye. And the motion carries unanimously. Oh, I see a hand now. Mr. Bennett?
Yes, Chair Foster, thank you. I didn't want to raise my hand before you voted. So I wanted to thank you, your board, Director Lindberg and her staff and the HCA for your consideration and process. So appreciate the work that you've done here, and look forward to moving forward. Thanks.
Great, thank you. And thank you for your team for doing your best efforts in submitting this budget. It obviously went pretty smoothly, and I think that reflects on the work that you all put in. So thank you. Director Lindberg, I'll turn back to you.
All right, 1 in the hopper, 13 to go. All right, so the only other hospital who was able to submit a budget that was within the guidance was Rutland Regional Medical Center. So to remind you of their submission, the numbers here have not been updated. I apologize. On the top note there, let me pull that up quickly for you. If it suits the chair, if we could maybe take a 10-minute recess, I could update this and make sure that we're looking at the right numbers for the record.
Makes sense. So we'll adjourn for 10 minutes. We'll come back at 2 p.m.
Okay, I really appreciate it. Thank you.
Of course, thank you. Member Lunge back. Member Walsh.
I'm here, thank you.
All right, great. Okay, we'll reconvene our meeting. Director Lindberg.
Thank you. A wise person once told me never to do math in public, so I appreciate the break. Reviewing the request from Rutland Regional Medical Center, we see that the approved growth from 22 to 23 was 2.4%, and they're projecting a growth of 6.2% over that 22 actual. But if you look at the growth from 23 to 24, it's 1.5% from that, or 1.4% from the projection in 23, with a 2-year growth rate of 7.7%. The charge increase in fiscal year 22 was 3.6%. I have a little footnote there. I wanted to remind the board that Rutland did submit a mid-year budget amendment request of 9% in that year that was not approved by the Green Mountain Care Board. Had that been approved, the growth from 22 to 24 would not have been quite as large as it is. So I just want to acknowledge that the growth in 23 was approved at 17.4%. So a lot of that mid-year clearly was rolled forward into the 23 request, which was acknowledged in the revised order for fiscal year 22. For fiscal year 23 to 24, the growth rate was, or the requested charge increase for fiscal year 24 is 5.62%. Rolling that across the 2 years, the growth is 23.02%. Just to add a little more color to that 22 rate at 3.6%, that was the 5th lowest approved charge increase that year, from a range of 2.2 to 8.3%. So that was a pretty low approval in 22. So, I just want to give that context in looking at these numbers. So clearly the NPR came in below the benchmark. So the next task is to see if the assumptions used were reasonable. So as Rutland details in their narrative and was further articulated in their hearings and follow-up interrogatories, they made the difficult decision to reduce some positions. And they are implementing compensation benchmarks to the median of similar hospitals. They also are in the process of a market analysis to review their compensation and have recently implemented some processes to evaluate criteria to review their CEO and establish the CEO's salary. The utilization assumptions were flat from fiscal year 23 to 24. But for a couple attempts for them to address some access issues. They were trying to expand some infusion services that are needed in the community and saw that the wait times were longer than they should be for some imaging procedures. And so are working to increase access for those services, which increased the utilization, but was within the expected range. The cost inflation for pharmaceutical expenses is tailored to the group purchasing vendor that they use. And the advantage of that information is it is tailored to their specific formulary and utilization patterns. And using that information, they came up with an inflation target of 4%, which is a little bit above the producer price index that was used for that. But seemed to be reasonable and probably more accurate than that benchmark in this case. The cost inflation assumptions were in line with the other hospital producer price index identified in the guidance, and in the follow-up inflationary assumptions, we see that they're all within the range. Commercial price changes, the charge increase that they identified or requested in their fiscal year 24 budget for the charge increase is 5.6%. This is near the middle of all the Vermont hospitals. And unless they had reduced their expenses, they were looking at an ask of as high as 9.1%. So they took some cost reductions in order to reduce that amount. They were hoping to reduce it even more than that. Unfortunately, some reductions in 340B revenue made it difficult for them to get that as low as they were hoping. Financial indicators. So during fiscal, Rutland's had some recent breaches in debt covenants, which has impacted some of their lending agreements. So they now must keep more days cash on hand and have some adjustments to their debt service coverage ratio and debt to debt capitalization ratio in order to make the borrowing feel safer to the lender. So, their budget accounts for that and make sure that they're not at risk of violating any more debt covenants. The process to do those agreements is actually quite costly, and so it is to the advantage to avoid those breaches whenever possible. Rutland did account for all known pricing changes in their submission for fiscal year 24. And from their narrative, it says they looked at both national and state estimates and tried to do their best to estimate the potential impact of the Medicaid unwinding that's currently underway. So again, all these assumptions seem reasonable, nothing that staff think was not justified in the submission, and so could recommend that this budget also be approved as submitted.
Okay, I'll open up to any board member comments or questions.
My only comment, I think, is that I support the suggested motion language. I really appreciate Rutland's, meeting the board's guidance with respect to NPR growth. I know that was very, very challenging this year, and I appreciate the efforts that they made to meet that guidance and the hard decisions that had to be made. So I support approving Rutland's budget as submitted. I might just ask if others agree that the budget order reflect the hope that Rutland continue the hard work necessary to get their CMI adjusted cost per discharge down closer to the median. I know that's going to be continued hard work, but I think it should be noted that they were high, and I think the cost reduction planning efforts that were underway this year will make get closer to that level. But just a note of that. But I definitely think that this budget should be approved as submitted, given the hard work that's been done.
I support the motion as well, and echo Member Holmes's comments.
I'm comfortable as well. Sorry, Dave. Shall I make a motion?
Can I just ask Member Holmes for a quick clarification? Do you think that comment needs to be reflected in a budget order, or that concern about the CMI adjusted cost per discharge, or do you think that is something that is more just a general discussion point?
Well, I mean, I think it's worth noting in the budget order. It doesn't have to, I think it's just a finding of fact that we will include in there, and perhaps there can be some language around continuing on the path that they've been on. I think is worth putting in the budget order.
Okay, I'd be comfortable with that.
I'll just ask Russ if procedurally there's anything we would need to adjust in order to reflect this, or if you're set.
No, I think that encouragement can be added. We don't have to include it in the motion language.
Wonderbar, thanks.
Well, I'll go ahead and move that we approve Rutland Regional Medical Center's budget as submitted with a 7.7% increase from fiscal year 22 actual to fiscal year 24 budgeted net patient revenue fixed prospective payment, a 5.62 charge increase from fiscal year 23 to 24, and subject to the standard budget conditions once those are finalized.
I'll second.
And I'll open it up to any public comment via the raise the hand function. Ms. Fox, the CEO of Rutland, please go ahead.
Yes, so first off, thank you for supporting Rutland and our community in approving our budget. It really was a difficult task for us. So I do appreciate that. I also would offer, as you consider thoughts around tracking both referrals and lag time, there are some true challenges that are outside of hospitals to be able to support. Would love to engage in a conversation with you around what that looks like.
I think we'd be open to that. Thank you for the suggestion. And there's probably many things that could be outside the hospital's control. Measuring it and understanding it will be the first step, I think, to really address it. So we definitely want that feedback, and thank you for offering. And congratulations on a good budget. You guys did a nice job. So I think.
And if I may just add, Chair Foster, I just want to.
Please.
I think I mentioned this in the hearing, but I think Rutland did a fantastic job with really clear, thorough wait time statistics. And one of the better hospitals submitting that referral and visit lag time information. So I very, very much appreciated that, recognizing that some of that is out of, the hospital's control, but the data that you submitted was really helpful in understanding what the wait times are like in your community. So thank you.
Sure.
Any other public comment? All right, I think we can go ahead and vote. All those in favor of approving the motion, please say aye.
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 Aye. Motion carries unanimously, and the Rutland budget will be approved pursuant to an order that will be forthcoming.
Thank you very much. So we'll be looking at hospitals a little bit differently who are above the benchmark when we reconvene next week, kind of the other side of the decision tree. Appreciate your efficient use of time. We're going to have an ambitious agenda next Wednesday, so it was a little bit difficult to predict the timing with the standard conditions. So always nice to get a little time back, but thanks for your patience with a few of the bumps along the way. Should be a smoother show next week, so appreciate it.
Thank you very much.
Thank you, Sarah.
Yeah. Is there any old or new business to come before the board? And is there a motion to adjourn?
So moved.
Second.
Those in favor, please say aye.
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 Aye. Motion carries, and we are adjourned. And thank you very much, Cassidy, and everyone have a good afternoon.
My pleasure. You too. Thanks. Bye.